We're going to end on a slightly different direction. I'd like to introduce Olivia Mandelbaum. She came to Tara about 2 or 3 years ago. She was our first Tara intern and has helped us enormously. And she's now in a graduate school for a PhD in psychology. And her Tara training has affected her experience in graduate school. And so she's going to share that with you. At the end, Lisa Dixon will give us a discussion of what she's heard, and then we open the floor for questions. Oh, Sarah, we need to get the slides up. I would just like to say that Alka is coming to Rome with us. She's going to speak at the third Borderline Personality Disorder Congress in Rome, where we have put in a workshop on our family work, and I'm delighted that she's going to carry her crusade even further, because I think it makes a very strong impact on how this disorder should be looked at.
Hi, so I'm Olivia Mandelbaum. I'm a doctoral candidate in clinical psychology at Long Island University, and I'm also going to be giving a personal account of my experience at Tara and the ways in which learning the Tara method in working with families and also learning neurobiology has impacted my experience in my current program. I'll probably skim through an overview of the Tara method because everyone did such a good job of describing it in detail. But I'll give you a brief overview of the LIU curriculum. And then I'm going to be addressing some questions that Valerie and I have kind of discussed over the last few years. Primarily, how can understanding the BPD family and BPD neurobiology help students in clinical psychology? And I'll be focusing on 4 different areas: understanding etiology and theory, creating compassion and empathy for BPD patients and their families, looking at case conceptualization and treatment protocol, and addressing new questions of research. As we just discussed, the TAR method encompasses several different programs. There's an 8-week TAR training course, a couples class, a weekend workshop, a new psychoeducation class for people with borderline personality disorder, a sibling satellite program that Sarah Piscatelli had started, and a mentalization class. The TARA method curriculum has 8 different components that are in Valerie Kaur's book, and they were developed over a 20-year period. TARA is the oldest family psychoeducation program in the world for borderline personality disorder. And it is an evidence-based family program. So when I was at Tara, I headed a research program in which we looked at outcome data from participants who had taken the Tara class. We found statistically significant decreases on measures such as violent arguments within the house, arguments, police calls, financial bailouts, hospitalizations, and most importantly, we found that a statistically significant portion of the time the relationship with the person with BPD had improved, which is ultimately what's most important and is the overarching aim of the TAR program. In general, in working with BPD families, I learned that the family is doing the best that they can do, that they're generally frightened, angry, helpless, frustrated, hopeless, and confused. They lack skills and they want to help, but they don't know how. Another thing that I learned is that each family member experiences the impact of borderline personality disorder differently and adapts accordingly to it. And each response and adaptation is equally valid. And you know, the HSBC ad campaigns really aptly describe this. I know Valerie will sometimes put these up in class. There's a quote there at the bottom that says, "Isn't it better to be open to other people's points of view?" And really observing the class, I was able to see how in any given event that goes on in the family, every single person has their own experience of what goes on, whether it be a crisis or some kind of family holiday, and that each person's perspective is equally valid, even the person with borderline personality disorder. In my program, which is a psychodynamic program in clinical psychology, we have several different components. We have 3 years of coursework. We have a lot of classes, but in general we have a year-long psychopathology sequence, a year of statistics, a year of research, a year of psychodynamic psychotherapy, a 3-semester assessment sequence, and 6 semesters of practicum. We also have a very large clinical component, so we're expected to do at minimum 3 clinical placements that are over the course of a year. Usually people end up doing 4. We have a clinical qualifying exam, which is similar to a dissertation, but it's just to demonstrate clinical competence. We have to do an APA accredited internship. And then we have a large assessment component as well. I have to do at least 3 supervised batteries, which are assessments of individuals that include both a cognitive part and a personality section. And we're required to do at least 3 more before applying for internship on externship. And in my program, we also have a fairly moderate research component. I have to complete an empirical master's thesis and a dissertation. So in my program, we do have a fair amount of exposure to training in research and clinical work for borderline personality disorder. We're taught to look at self-reports that assess for borderline personality disorder, like the PAI, the MMPI. We're also extensively trained in projective measures, like the TAT and the Rorschach, and we know how to look for signs of borderline pathology in those. We're also exposed to a fair amount of patients with borderline personality disorder. I think almost every single clinician at the clinic that I work at now carries at least 1 borderline case, which is typical of a community clinic. So we're, well aware of that diagnosis and how common it is. We're also exposed to a lot of theory on borderline personality disorder. We look at Kernberg's theory and transference-focused psychotherapy, Babin and Fonagy's theories on attachment and mentalization. We now have a special seminar that I just took on DBT, so we're exposed to the biosocial model. And we do get some exposure to clinical practice and evidence-based treatment for borderline personality disorder. Like I said, we have the DBT class, and then there are 2 faculty members who are actually transference-focused psychotherapy clinicians. So we are exposed to some evidence-based treatments for the disorder. And those 2 faculty members also do research on the social cognitive processes underlying borderline. In general, I think that graduate schools can overlook issues relevant to borderline personality disorder for a host of reasons. Firstly, there is limited access to training in evidence-based treatment for borderline personality disorder. So if there's not a faculty member who's trained in one of the evidence-based treatments for borderline personality disorder as a student, you just simply won't be exposed to it. And this will lead graduate programs to emphasize clinical competence with some disorders at the expense of others. So if your faculty simply happens to have a very strong emphasis on studying ADHD, for example, that may come at a cost to studying other disorders. So you just may have a less balanced clinical training. There's also a very, very minimal emphasis on family in terms of the treatment of individuals, despite the fact that we talk about families in the etiology of borderline personality disorder through almost any theoretical orientation. So whether it be the biosocial model, whether we're talking about attachment and misattunements, we're well aware theoretically of what borderline families are supposed to look at, but we've really never worked with families in Western clinical training. And as a result, we have little practical training, and there's really no motivation to research family issues. And I also think, too, it's important to state that researching family issues is very complicated because there are many more variables that you have to look at and control for. And so I think the field as a whole kind of shies away from doing family work. It's no surprise that BPD patients are stigmatized by the clinical community, and this, of course, occurs in graduate programs. Unfortunately, people still carry the misinformed perspective that these patients are treatment resistant, impossible to treat, or rare, none of which is true. And oftentimes, I think in graduate schools, this perspective can be reinforced by a lack of resources in treating BPD patients. So, no access to evidence-based treatment, poor supervision, or just sparse supervision, and also the fact that there's no formally established consultation team. So, most of the times when you're a graduate student, you don't have access to a consultation team. So, I'm carrying the sole burden of responsibility for any borderline patient that I have along with my supervisor, but most of the evidence-based treatments for borderline personality disorder also have a consultation component in tandem with it, because these patients can be very difficult to deal with, and oftentimes you need support from colleagues. And in graduate school, that doesn't happen. Also, I know Mark Zimmerman just talked about this at NASSPD, but borderline is really an uncool disorder to study. So students may be motivated to study hotter diagnoses like ADHD, bipolar disorder, autism, etc. Borderline personality disorder just simply is kind of unsexy to look at. I think also the tenure system can lead to very strong generational divides that persist for many years. Borderline personality disorder is a newer diagnosis. It really wasn't written about prior to the 1970s. And I think that when older faculty members don't keep up to date with the newest diagnoses, the newest treatments, the newest research, it can perpetuate outdated perspectives and lead to theoretical and empirical biases. I also think graduate schools can implicitly foster an us versus them attitude towards patients. I know Kernberg has written about institutional authoritarianism in analytic training institutes. Basically, in graduate school, there's a very strong hierarchy between senior faculty members and junior faculty members, upper doctoral students, lower doctoral students. And so the people who are in training are really the people who get the brunt of all this, and who better to act out any feelings of resentment or aggression than on our borderline patients. Clinical training can also evoke personal insecurities that can be projected onto patients. I know when I first learned about borderline personality disorder working at Tara, a lot of things were brought up within myself about the ways in which that I might be similar to borderline patients, and it might be very easy to say they're the person with the problem, they're difficult, they're impossible to deal with, than to really acknowledge the aspects of myself that are difficult and impossible to deal with. In general, graduate students are overworked and underpaid. We don't have very large stipends, and we have a ton of work. So this leaves little time for own psychological support, and I think this can really, really impact how we interact with patients, unfortunately. So I'm going to make several recommendations for how graduate programs can do a better job of educating graduate students about borderline personality disorder. The first thing is that graduate students really need to be reminded that theories are not facts. So this is a quote from Stephen Mitchell. He says, "Theories are not facts, observations, or descriptions. They are organizational schemes, ways of arranging and shaping facts, observations, and descriptions." So a theory is not a fact. The biosocial model is not a fact. Attachment theory is not a fact. It's simply a way for arranging and making sense of some facts that have been arrived at through hypothesis testing. But the problem is that when developmental theory is misinterpreted in terms of its veridicality, that it can unintentionally lead to bias and stigma against the BPD family, and it can also really misinform treatment. So if you're so certain that your patient grew up in an invalidating environment, that can really impact treatment, how you view their family, etc. We well know that the etiology of BPD is such that genetic factors somehow interact with childhood experiences and give rise to the components of psychopathology found in borderline personality disorder: affective dysregulation, behavioral dysregulation, disturbed relatedness. But BPD is found to be, at the very minimum, modestly heritable, on par with a lot of neurobiological disorders that we view as genetically based, like bipolar disorder. And I think because of the vernacular that clinical psychologists generally use in training, we tend to sort of privilege the right side of this model over the left side. And so, for example, we might use the language of psychology instead of neurobiology, but there are a lot of connotations to doing so. So Bateman, for example, might talk about the hyperreactive attachment system, whereas a neurobiologist might talk about the role of oxytocin. But using terms like hyperreactive attachment system have a lot of implications for family dynamics, for ideology, and so when we become used to using terminology like that, it can kind of lead to a sort of splitting off and ignoring of the really high genetic loading that's necessary for this disorder. I think in general that an awareness of neurobiological underpinnings can increase compassion for BPD patients by putting symptoms into an organizational framework that creates understanding. And graduate students should really be exposed to neurobiological findings. And I think that neurobiological findings could be disseminated in clinically relevant, user-friendly terms. I think Valerie does a really great job of doing that. Clinicians should be aware of the latest research developments in neurobiology, and that should start at the graduate level. And clinicians should be able to explain symptoms to patients using the brain. So if graduate students simply get in the practice of going over with patients what the brain looks like, how it works, how their brains may be wired differently, it may be very helpful to the work. One of the findings that's most important for me when I began working with BPD patients as a young clinician was understanding BPD amygdala and prefrontal cortex responses under stress. I know Valerie went over this, but Antonia New has a study where she found that under conditions of threat that the prefrontal cortex of someone with borderline personality disorder is likely to downregulate. So they'll lack the sort of normal cognitive controls that someone might have under conditions of stress, and they become impulsive. And this can really impact how they act with you in the room because it's stressful to come to therapy in the first place. And so when someone walks in the room and begins acting impulsively, clinicians might feel manipulated or aggressed against, or that someone's acting out with them when really there's something neurobiologically going on with them. And if the clinician doesn't understand that, it can really lead to a lack of compassion and empathy. Similarly, in at least the psychodynamic program where we're trained to use neutral faces, we need to be aware that borderline personality disorder patients show increased amygdala activation when viewing neutral faces. They interpret neutral faces as angry and then interpret this anger as directed towards them. And this is compared with controls when viewing pictures of human emotional facial expressions. So it's just important to be aware that when someone walks into the room with you and they have borderline personality disorder and you're sitting there with a neutral face, that they might have some really strong reactions to this. We also came up with some recommendations for graduate students in terms of case conceptualization and treatment protocol. Young clinicians should simply be aware of the high incidence of comorbidity. If someone comes in and on intake forms reports that they suffer from alcoholism or have some addiction, it's likely that they also have borderline personality disorder, and that's just a very easy way of knowing that that could be a possibility. If someone comes in and they have 5 or more diagnoses in the past or future, if they have ADHD, oppositional defiance disorder, depression, anxiety, an eating disorder, it may indicate a BPD diagnosis. That should just be a red flag. I know when I look at an intake form, the first page, that if someone presents and rates all of those diagnoses, I know immediately that I'm going to assess them for borderline personality disorder. I'm not going to wait around to figure out what other disorder I'm going to diagnose them with. Also, BPD patients need specific evidence-based care, and clinicians should also be aware of this. So if someone has borderline personality disorder and presents with depression, the treatment regimen is going to be very different than if it's just an average person who comes in with a biological depression. When an average person presents with a biological depression, they may respond to an antidepressant regimen and cognitive behavioral therapy for depression. But this is not the treatment protocol for someone with borderline personality disorder. They need to be referred to specific evidence-based care, and clinicians should know this. Furthermore, even when they are referred to evidence-based care, it's important to be aware that borderline personality disorder patients do not constitute a homogeneous group. There are over 294 different ways of arriving at the borderline personality disorder diagnosis. And so, depending on the person's specific constellation of symptoms, you may decide to refer them to one treatment method over another. If someone's presenting with a lot of parasuicidal episodes, we may refer them to DBT first. If they're having a lot of interpersonal problems, maybe TFP is the better treatment of choice given what's going on with them. In general, I think that this is something that young clinicians do a lot, but broad etiological assumptions based on self-report or theory should be left out of intake reports, case conceptualizations, and testing reports. So a lot of times, young clinicians will make inferences based on what patients come in and report, or even based on their theoretical understanding of borderline personality disorder, and include these in legal documents. So for example, if the patient comes in and they report being abused, the person might state patient has a history of abuse rather than stating patient reported a history of abuse. So I really think that young clinicians should be taught to use descriptive explanatory language instead of inferential language for legal documents. And of course, BPD treatment should incorporate family interventions whenever possible. This is something really the whole field is looking towards doing now, and graduate students should be aware to do this as well. Mark Zimmerman gave a really great talk at NASSPD where he said, just outwardly that BPD is vastly under-researched. So this should be an area that graduate students in clinical psychology are looking to do empirical work in. Psychological mechanisms should be studied alongside their biological underpinnings. There's a paucity of research on the effect of BPD on siblings, partners, and adult children. There's really hardly any empirical work done on these areas. We need more effective methods of EBT dissemination. I remember I asked David and Fonagy once at a conference who does dissemination for mentalization, and they said, "What are you talking about? We're the only two people who do it." So if you're curious as to why there's no mentalization in the United States, that's why. And we should have people that are researching how to get the latest evidence-based treatments out on the ground level so that clinics can use them. We need more research on what works for whom, so what kinds of patients respond to what kinds of treatments under what kinds of circumstances. We also need research on available interventions in the absence of available evidence-based treatment. So if you live in Hawaii and there's no transference-focused psychotherapy, dialectical behavioral therapy, or mentalization therapy, can we study family interventions, community interventions, school interventions? And then lastly, we should research the cost-benefit ratio of BPD treatment. I know they do much more of this in Europe where healthcare is socialized, but BPD is an economically costly illness, and it would behoove the rest of the field to know the economic upsides to having people be in longer-term evidence-based talk therapy for the disorder. And then just to conclude, we need established BPD clinicians and researchers who can teach a new generation of clinical scholars. The more upper-level academics we have who are competent in treating borderline personality disorder patients and who are well aware of the research issues facing this population, the more likely that younger scholars will have access to learning about this disorder. And I'll just conclude with a quote from Neil deGrasse Tyson. He said, "The problem in society is not kids not knowing science. The problem is adults not knowing science. They outnumber kids 5-to-1. They wield power, they write legislation. When you have scientifically illiterate adults, you have undermined the very fabric of what makes a nation wealthy and strong." And I think that this very much has to do with where the field is headed in terms of borderline personality disorder. We really need upper-level clinicians and researchers who can teach us how to do the work. Thank you.